Many of the drugs that we use were not developed for glioblastoma. They're developed for breast, lung, colon, whatever cancer, and we're trying them in glioblastoma because that's all we have. During my training at Dana-Farber and here in California, we did develop a drug that hits the Achilles heel, the cancer stem cells of glioblastoma. And excited to say, after
Whoa.
9 years of working on it, we just got our phase one IND approved. So I'm super excited that we'll be able to do clinical trials on it later this year. That's was designed specifically for glioblastoma based on an understanding of glioblastoma stem cell
High
biology.
five. So if you're on social or news media at all, you've probably heard about these stories of these like brain cancers and brain tumors that are popping up, right? There's a high school in New Jersey that everyone's talking about on TikTok. Why are there so many people that graduate from there having brain tumors and not unfortunately dying young? And then you have the Phillies that are talking about the stadium possibly causing brain tumors as well. There's not a lot of things we know that may increase your chance as a risk or exposure with brain tumors. But if there is, who else better to discuss it with than Dr. Santosh Kesari, who is basically just an insane, forefather when it comes to neuro-oncology and brain cancer stuff and brain tumor stuff and hopefully really changing the way we treat brain tumors because right now we're not very good at it. It's a stubborn thing. It's like very, challenging with all of its mechanisms. And unfortunately, the brain is a place you can't go, picking around at. So I'm very excited to have Santos. He's basically what I call a pan director, but specifically, he's a director of neuro-oncology at the Pacific Neuroscience Institute of Providence, St. John's Health Center. He also has leadership roles with translational research. He graduated from UPenn. He's been regarded as one of the top 1% of neuro-oncologists and neurologists in the nation. He's both a neurologist and a neuro-oncologist. So, where do you start with someone like Dr. Santosh Kesari? Well, the first question I asked him was, these stories about the baseball players in this high school, do we think there's something really there that is like, oh man, that's the thing that's a big cause for why they're having these brain tumors?
Yeah, I read the article, and obviously there's a lot of data and information missing from it, but it is unusual to have such a high number of patients in the same area develop a particular type of brain tumor. Uh, but I think an investigation is starting, and that's appropriate. Over the decades, there have been various associations with environmental factors. There's been reports of airplane pilots having increased risk of brain tumors, firefighters increased risk of colon cancer and brain tumors as well. So it's hard to really tease out what is real or not until a really formal epidemiological study can be done. And I believe they're doing some radiation assessments to see if maybe the radiation exposure is higher in that school or that community compared to the other places. So I think
Yeah,
it's
and that's
something that needs to be reviewed and assessed, and we'll see what they find.
yeah, and I think that's what caught my attention is like with firefighters, you're breathing in smoke. In the South, they call it the Bible Belt, but also the Cancer Belt. They're like, is it diet? Is it a lot of the industrial stuff? But those again, you get this kind of like exposure of your normal cells, and when they replicate, they get little damages, right, with pollutants and things that just kind of mess up the DNA and allow it to all of a sudden go rogue, escape your immune system. So at least like in conceptual way, that makes sense. I think the thing that's really tripping people up about the central nervous tumor is like really short of radiation, which makes sense because then you're having like a direct exposure. And we don't mean just like the UV rays from the sun. We mean something that's actually that penetrates and goes onto that tissue because again, you usually need something to invite something bad, like a cancer and those mutations. And that's what makes it unique. We know that if you got treated with radiation, like you were, attacking something in childhood, then you're killing those kind of like bad cells. But then you have some collateral damage, like aptly named. And then so sure, those make sense. But that part is weird. And there's also a story about baseball players kind of having a similar thing. Is again, what is it about this otherwise really this blood-brain barrier and the sanctuary and how it's different systemically, which is good and bad. Sometimes it's protective, but sometimes it makes us hard to treat as oncologists to get in there because it's a sanctuary. That was also what was concerning when it comes to these baseball players. I think there were six now, right? That has like some kind of brain tumor, central nervous thing.
Yeah, again, a more recent story but over several decades. of the Philadelphia Phillies, and they were in the old Veterans Stadium, and they were using apparently radar guns to track certain things, and that might have also caused an increased exposure to radiation. Again, it's a hypothesis. It's not really clear that it's really causing that. The 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 difficulty is that these exposures, whether it's cell phone, there's been a lot of data about cell phone exposure and causing various types of cancers, from brain tumors to parotid tumors, but radiation exposure from the environment, and a certain closeness to facilities, water or electrical devices or radiation, nuclear power plants, things like that. But it's really something that needs to be explored, and there's been really no definitive um, causes, links rather, but mainly because it takes like 10, 20, 30 years from the exposure to the time you get a problem. And that's why it's difficult to make these associations. For instance, the cell phones of 20, 30 years ago were much more powerful than they are now. And we're using a lot of wireless and speakerphone. So it's hard to even see the effect anymore if there was an effect. There's various studies that showed, especially in Europe, in the Scandinavian countries where they had good public health records, of a causal or epidemiological association between exposure time and certain types of tumors.
So you were saying it takes like, 20, 30 years to really see if that exposure causes a tumor or a cancer. And if I understand it correctly, the reason is that for that is because you need the exposure, but then you need like a true perfect storm and series of events to really fall in just the wrong places to then enable and liberate the regular cell, right, whether it's central nervous or not, to turn into cancer. And I think that's what makes it challenging. But to your point, you were saying that cell phones, the power was more in the past. Is it true? Like, is there data to support that using cell phones does in some form cause cancer? Like today, is there statistically significant, I guess, data, or is that something just still under investigation?
There was old epidemiological data that suggested an increased incidence in certain populations such that had good public health records, such as in the Scandinavian countries, and it was associated with acoustic schwannomas, as
Mm.
well as primary brain tumors, gliomas, and parotid gland tumors. And there was a laterality and a lot of other variables that seemed to suggest that the association was pretty strong. But many other studies didn't show an association, and over the years, obviously, cell phones have gotten less energy, and we're not holding them to our head anymore. We're using the speakerphone or wireless or headphones.
Zoom.
So that epidemiology may not hold up, and certainly we haven't seen an increased incidence of brain tumors over the years outside of age-related increase. As we age, we tend to get all kinds of cancers, and we know the reasons for that. Our immune system gets weaker. We tend to get more genetic mutations build up over time, and as we age, we're at increased risk of cancer. So that's really the reason why we see more numbers of cancer patients than in the past, but not necessarily an increase in incidence at any one age group.
That makes sense. So let me ask you point blank. Has have do you personally or did you used to kind of avoid putting the phone up to your ear,
Yeah.
just being the wizard that you are in the neurologic oncologic world?
Yeah, certainly. You can't ignore the data and you can't ignore the concerns. So
I feel
yeah,
the same.
for my kids are teenagers now. When back then, about 15 years ago, we definitely were concerned and avoided all kinds of radiation emitting devices, in particular cell phones, usage in our kids, or limited the usage. So
Yeah, for sure.
there's so many environmental things that obviously diet is important, right? For a lot of medical conditions, not just cancer development. There's a lot of things to know, understand, and prevent in terms of the prevention part of healthcare that we can do better to prevent cancers in the future.
Yeah, and kind of speaking on the same note, Ever since I heard this, I wish I didn't because it's just kind of really messed with me and just adds to the anxiety and stress that I have kind of day to day about all these other things, which does lead me to having less sleep. So the question is, or what I was told was, when you sleep, and this is a very, layman way of putting it, but it's almost like an oil change for your cerebral spinal fluid, and basically it's like a cleanse. I'm going on an
Yeah.
all, fluid diet cleanse, and that apparently true sleep and deep REM is the only circumstance that really helps that exchange of toxins and kind of maybe permeate out of the central nervous system. So ever since I learned that, I'm always like, am I really just making myself at an increased risk of a neuro tumor because, I don't get into that deep REM kind of wash cycle? Is that at all accurate to any effect?
No, you explained it perfectly because only in the last 5, 10 years we've understood the importance of sleep and the importance of detoxification of the brain, basically. So lying down and sleep is helpful for clearing all the toxic metabolites that build up in your brain, much like urine is for blood. As
Right.
if you don't, that is clearing your blood basically of toxins and other things to keep homeostasis. Likewise, in
That's
the
why you
brain,
require dialysis. Right.
yeah,
Like you have to get rid of the toxins, otherwise it messes everything up.
exactly. And in the brain, there is constant dialysis going on, actually. The blood goes to the brain, CSF is made, and amyloid and all these bad players are cleared. And so sleep and maybe reclining and a variety of other factors are important for clearing these toxins in the brain that build up when we don't sleep adequately.
My mom will be very happy, and I think she needed me to hear this, and I maybe shouldn't have asked because I'd always was in the back of my brain, pun kind of intended. So I think that is a really big stimulus, though, for me to sleep better. Because I mean, let's be honest, when you don't have that, oil change, it does lead to true like depression and worse headaches, and then obviously the central nervous system is like the mainframe computer major database to like for your perceptions of pain in your muscles and having these what we call myalgia, all of that stuff is neuronal. And so if you're not cleansing that, then I could see how that would be legitimately problematic. And that's why I stress to sleep apnea patients too. They're like, well, I feel okay. And I'm like, if you have sleep apnea, you need that deep REM, whether you know you're sleeping or not. It does so much more than like just how you feel. And the evidence is showing that from what it sounds like you're saying.
Well, it's not just for your brain health, it's also for your whole
Oh,
body
100
health.
other, yeah.
Yeah.
Right. Cardiovascular, yeah. I mean, all the things for sure.
And probably immune health. I suspect everything to me as after doing this for 20 plus years, I loved immunology in medical school, but now I realize the real importance of immunology in all aspects of our body, every single organ system. There is a huge role for the immune system in terms of maintaining health and also causing all the problems that we have, whether it's cancer, cardiovascular disease, or dementia.
Oh, I mean, it's extraordinary. I remember when I first got on social media, everyone would be like, it's all about your immunity. We just need to boost that up. And I'm like, why are we just saying all immunity? It's not that simple. It is in a very broad way. Like, but the problem is people, it's very difficult to appreciate how complicated the immune system is. Like, it has an entire network. You don't just take an immune booster because what does that mean? Is it the neutrophils from the bone marrow? Is it lymphocytes that fight cancer? Is it antioxidants? I mean, there's just so much involved into it. But I love that we are obviously going to immuno-oncology, and I know you have work and experience there. And so it's a whole thing, but it's something that needs to be in some way revered or respected to the degree of saying you can't understand it overnight. I mean, it's truly academic and complicated. Now, um, when I read this story about that high school in New Jersey, where a lot of people were coming down with these brain tumors, whether it was cancerous or not cancerous or glioblastoma, my theory, without looking at anything else, I was like, I know there's not a lot of exposures, occupational or whatever behavioral that influence that sanctuary that is the central nervous system compared to just smoking and all these other things that occur elsewhere. So my first thought was, is it possibly possible that if it's in a remote place and it's a high school that catches all the entire community, that they have one of those inherited mutations, right? So we talked about risk factors, but obviously one of the biggest ones are inherited. But I need to say that by saying that cancers by far are not passed down to you or germline or inherited and stuff. I know a lot of people say I don't have to worry about cancer under my screening because I don't have it in my family history. It is like almost, I mean, 85% plus, 90%, especially when you get older towards retirement, is something that happened in your lifetime. That perfect storm happened in your lifetime. However, we know that there are things that are kind of unique when it comes to kind of stranger, more atypical things like glioblastomas, sarcomas. And so I looked it up. I said, what's the population? Is it kind of rural area? Maybe, you just, even if it's a couple of degrees of separation, you can just carry these mutations, right?
Yeah, so the hereditary component of cancer and other diseases is also underappreciated, actually. And in this new generation of sequencing, where we're sequencing all cancer patients to find targets to treat them, we're finding some very interesting results. So, the old school way of doing genetic testing is to ask the patient, cancer patient any family history of cancers. And you go through a detailed, with a genetic counselor, detailed family history. And only if they meet certain criteria, then you do one test,
That was it. Those are the
TP53,
metrics. Yep.
BRCA, things like that. But now, when we're doing cancer sequencing, we are actually getting data on the mutations at the genetic level of the person, not the cancer, are being identified in many of these cases. And it instead of like less than 1% of cancer patients having a hereditary component, there's at least two or three abstracts in the past year or two, and many, many publications as well, have documented, like in the general population of cancer patients, that it can be anywhere from 5 to 15% of cancer patients. There's a genetic underlying mutation that's of relevant as a hereditary mutation that has implications to the rest of the family in terms of testing and screening and so on. So I think because we're screening so broadly and not just doing one single gene based on a detailed family history, we are identifying that, in fact, the genetic component is much larger than we previously thought. Probably still, in the 10 to 15% range, not uh, super large, but much bigger than we
Not
thought
like the
before.
1%.
Yeah, yeah, and this has a lot of implications for targeted treatments, response, and then if you think about the the other revolution in genetics is looking at everything else and how pharmacogenetics affects response to drug, metabolism of the drugs that we give, and then then you get into the microbiome and everything else that can predict uh, predisposition to cancer, but also response to treatments of various sorts that we're using, whether it's chemo, radiation, targeted therapy, or immunotherapy. We're identifying the underlying cancer genetics as well as the person's genetics have a huge underpinning to a variety of outcomes. So we're learning a lot because we're testing a lot in our patients these days, and we're getting so many insights, and the science, we just can't keep up really in many situations to the vast amounts of data that we're generating. But people who can understand it and take advantage of those findings can maybe potentially improve treatment response, as well as uh, identify a genetic disorder that maybe the family wasn't aware of that would have some preventative implications.
Right. And so, that's an important point because before, say we knew something works in a lab, we're like, okay, it works in mice models. We give it kills the thing effectively. And we give it to, X number of people and it's working in in some subsets, even though the tumor looks the same, we're like, why isn't it working? Why aren't we having the same response? And in other ones, we're like, why is it so, profound? And so the people that don't know, we are testing what's called germline mutations. So germline means it's like something, the coding was already there. When you were a tiny little fetus, you had that coding. Some of them are good, some of them are not so good. One example I use is like basically like a home run. We were talking about baseball earlier. I don't love it because it's not a home run. You're not trying to get to home base, but it's literally how many bases are you along to get if the home run plate was bad and it was a cancer cell. That inherited mutation doesn't will you to necessarily have cancer, but you're already one step. So if I incur one for colorectal cancer at 30, it's like you're already at that base. Doesn't mean necessarily that you're going to end up there, but you've accelerated the process, which, as we know, are just this perfect storm of less than favorable mutations. So that's germline. That's like what you were given this little fetus, like I said. Now, somatic means, say, for a little inaccuracy, but say your cells are all fine. They're coded exactly the way the Statue of David would have been coded, which I hear his framework actually wasn't even ideal. But I hope that the metaphor is not lost. If it was perfect that way, then somatic means these series of mutations happen over time, and then you have these mutations that are just inherent to the cancer cells, the properties of the cells that ended up having their own little, rogue kind of evolution in the body and escape the immune system. So that's the difference. And now with germline, we realize, hey, I think it does dictate how we treat things. Like we got all excited about BRCA positivity, germline, and then and platinum drugs, right, in breast cancer. And then now we're looking at, BRCA-like mutations, including BRCA, which is hereditary recombinant DNA impairment, or basically HRD. You look at it in ovarian cancer, and that actually qualifies you to get therapy, a PARP inhibitor. And that can be whether it's germline or somatic. So we're realizing we're teasing all these things. So when people ask, well, how come we haven't cured cancer yet? Like, it's like, that's what happens. We're so just like, confident when you take it in mice models, and then you realize there's all these other factors, epigenetic, and what series of things you have that are or are not favorable, right?
First of all, we're billions of cells are dividing in our body, and as they divide, there's an extremely small percentage of errors that are made in the DNA replication. But when you have billions of cells dividing every day, as you can imagine, even though it's 0.0001% of an error, some cells are going to have a lot of significant errors that are not corrected. And then that could initiate the initial process of cancer. And I think as you discussed before, sometimes the immune system, when it's healthy, can detect it and get rid of it, especially when you're young. But over time, as we age, the immune system ages as well, and those mutations start to take on more mutations and then can cause cancer and escape the immune system. Now, there are certain mutations, such as the one you mentioned, BRCA, that are significant and really implicate specific types of treatments, like the platinums or the PARP inhibitors. But in hard cancers like glioblastoma, we see some of those same mutations, but patients don't respond. And the reality is, these tumors are very heterogeneous, meaning it's really not one mutation. These malignant, hard to treat tumors are not so simple. They have multiple mutations, multiple things going wrong in them, so that they evade the immune system. They just grow out of control, and they really adapt to be very aggressive. So even though we have many cases of patients who respond to targeted therapies, because they have a mutation that's really significant, what we call a driver mutation. There are many other mutations that go along that can also contribute to resistance to a certain treatment. So what I'm saying is, cancer is very complex, and it's also very individualized, because one person with one mutation may respond to an EGFR inhibitor, for instance, but another person with the same EGFR mutation may not respond because they also have 10 other mutations that make them resistant for one reason or another. So what we're learning individually in every single patient that we see in our clinic, when we do this profiling, we're finding all kinds of mutations. And I think eventually, although we see single agent responses when we add a targeted drug to a particular patient, the reality is we probably need to figure out how to do better combination treatments that are going to really hit it hard, because most patients, at least in glioblastoma and many other hard to treat tumors, don't have just one driver mutation or one really important mutation. We need to have combination approaches, and that's, at least in GBM, that's what I think about, is how can we do better with combination approaches, and how can we figure out which combinations are going to work when you have 10 mutations.
Right. I think, that's full of metaphors, but that is what makes it challenging. It's like there's what we also call, escape mechanism. So that means if you put some pressure on something, right? If you're playing sports and you decide, if Shaq is on his team by himself, you're gonna say we're just gonna neutralize Shaq and we'll be fine. Okay, that's fine. But what happens when they all, get a little older and they all start coming together to get the ring? Now it does not suffice. You can still have the same strategy, but then his buddy Kobe, rest in peace, like still think about that. It was very troubling. But then he'll have his buddy, Kobe Bryant or whoever he played with, like then adapt. And so that's what you're doing. You're trying to neutralize the escape mechanisms of the pressure you're putting. Shaq's team will be good if you can't neutralize him. You find it, you get excited, but then he has other players that either come on board in the season and stuff and then start coming out. And it sounds almost like offensively simple in that regard, but that's the truth. But they have a bunch of them, right? Or it's like the reason Saban or Belichick just keeps winning. Like they know they can adapt, they can have a plan at the beginning, and then they just at halftime they say these are the things that we're going to do to one exploit the other team on their weak side. So that's escaping the immune system or even monopolizing the environment to make it favorable. So you're exploiting the thing that you sense as weakness, and then the other side is, and this is how they're hurting us. So we're going to execute X, Y, and Z so that it's rendered ineffective. And so you really have to be prepared in this kind of multi-modality approach to do that. And a lot of experts, I certainly consider you one, say that that is the future. The future of a cure for cancer is really hard to say. A future for anytime soon of curing all cancer is really hard to say. But being able to die with cancer and not die from cancer, and having a cocktail of treatments or medications that hopefully aren't systemic chemos and are all targeted, that seems like a plausibility. Is you take this cocktail, if you have herpes, you take a cyclovir and you have no detectable, viral load, and HIV even, you have these couple of medications. Same kind of concept, which is adequately just attack it literally on all ends, and then hopefully it just either stays at bay or just never appears with minimal toxicity, right? And so that's the ideal goal. But in your beautiful metaphor about the billions of cells and the 0.0001% that escapes the mutation, that's why surgery is still and will always be the way to really cure, right? You find that colony early enough before it develops the mechanism to throw an anchor or a fishing line and then escape and get in the blood vessels and lymphatics and spread. And before all that stuff happens, if you could take out, liberally the surrounding tissue, that's always probably always going to be your best shot, no matter how many billions of dollars we spend on targeted therapies.
Um, yeah, I agree with that, except in the brain. We can't take out normal
Sure, you
tissue.
can't take out that. Yeah, exactly. You're a
No,
glutton for punishment because you
yeah,
picked the hardest tumor already by its inherent properties on why it's so bad, aggressive, and smart, and then you also pick the one that you can't use the simplest, most definitive tools on. Why you do this to yourself, Dr. Santosh?
well, when I was in medical school, I really loved neuroscience and the brain. And when I was thinking about what I wanted to do, actually, I was thinking about neuroimmunology because I loved multiple sclerosis and autoimmune disorders. And but I thought, brain tumors was there was so much heartbreak, and people just there's no good treatments at all. And I thought this is something I want to do because I want to figure it out, and kind of motivated me to work hard to think about the disease and think about how to do better. We made progress in the last 2 decades, but we still have a long way to go. And on that note, what I've been doing is thinking about innovative approaches. And one of my thoughts, maybe you'll agree with it, is that sometimes the hard guns that we use, right, surgery, radiation, and chemo, are needed because we don't have good other treatments, right? If you remember, and you know the story of Gleevec for CML, a disease 20 years ago, everyone died within 6 months, and it was a driver mutation and clearly drove that disease, BCR-ABL, and Gleevec or imatinib was developed for that specific mutation, and those patients now have normal lifespans. Now that is the ideal goal. That's like the magic that we all hope that we can do for all of our cancers. And certainly for breast cancer, melanoma, colon cancer, many other cancers, we've identified similar mutations, developed targeted therapies, and have made amazing progress. Not on the scale of CML, but nonetheless, huge, huge advances. And in brain
Yeah, like
tumor,
HER2 positive. HER2 positive was like the worst thing. You would dreaded it because it's so aggressive. And now you're like, please be HER2 because we found it and we know how to attack it.
yeah,
And
yeah.
it's more favorable than being negative.
Yeah, exactly. HER2 was a marker of bad outcomes, but when you figure out and develop a drug for it, it's actually a marker of good outcomes. So you can change the whole perception of whether it's a good marker or bad marker.
Right, of good or
Have a
evil,
better
yeah.
drug
That's
for it.
actually a big philosophical concept.
Yeah, yeah,
Yeah, that's a big, yeah, like, good over, or man over whatever, because it's the same thing that like was ugly and all of a sudden, like, thank you for like letting us know. That's crazy.
so let me give you another example or two. So CNS lymphoma is a one of our favorite brain tumors because we know we can actually essentially cure them. Okay,
Right?
in the old days though, because we didn't have good drugs, methotrexate at the standard dosing for systemic lymphoma just wasn't working. It wasn't there wasn't enough penetration into the brain to kill the brain tumor. So back in the old days, we would actually resect a lymphoma, radiate a lymphoma, and everyone would die within a year or so. But when we figured out how to do high dose methotrexate such that enough drug gets into the brain and CSF, and then able to manage the toxicities, of course, as well, those patients respond amazingly well, have well over 5 year survival these days. And now with the immuno-oncology and newer drugs, they survive obviously even much longer. And I mean, that's like our favorite brain tumor to see, but very uncommon, but nonetheless nice to see those amazing responses. And that's kind of the hope we have for glioblastomas. Now, over the years, we have seen amazing responses. If you have a BRAF mutant brain tumor, glioma, those patients can respond very well to the same drugs that we use for melanoma, BRAF MEK inhibitors. There's many, many examples of that over the years, and I think even with EGFR inhibitors, we've seen responses over the years. So there is a lot of progress. It's just the heterogeneity is fairly vast in terms of the sporadic glioblastomas that we deal with. But now, compared to 10 years ago and certainly 20 years ago, we have like hundreds of targeted therapies out there. We don't have enough time to test all of them, but we do need some big data science, figure out what all these mutations each person has, and have an algorithm to say these two drugs are going to be the best, or two, three, four drugs are going to really work the best for this particular patient, and then identify and do trials or real world type of experiments, because these are all available in the market, and certainly because our standard treatments don't do a good job. Many of us do, when we don't have trials, do a lot of off-label treatment based on those mutations, and we do see responders. I had a young kid, 16-year-old, when I first saw her, who was on hospice, had a mutation that suggested response to a breast cancer drug, everolimus, and she lived well over 7 years with just one drug. And we have many, many examples like that. So on an individual patient basis, we can see amazing effects. Whether on a population, when we do a trial, we may not see it because we're not selecting based on the markers. Many of these trials still, at least in brain tumors, are very immature still in terms of linking the biomarkers to a drug or combination of drugs to have a potent effect. But the other real reason I use the lymphoma example is that 20 30 years ago we would do surgery and radiation and then chemo, and then they would die right within a year. But now we do a biopsy. If we suspect lymphoma, we do a minimal biopsy, not a big craniotomy. And once we diagnose a lymphoma, we give high dose chemotherapy, targeted therapy, immunotherapy nowadays, but the tumor melts away, no radiation at all. And I think in glioblastoma, we do have to do a resection because the tumors are causing symptoms. But, can we do something different? And so my approach has been to try neoadjuvant approaches, meaning before the radiation, and this has been done in other cancer types, but also even in glioblastoma, mainly in the European countries. They've done many of these studies where you can give chemotherapy before radiation or combinations of treatment, and there was a reasonable response rate, not super high. But with all the new drugs that we have, should we use that approach? And can we do that? And we've done a pilot study looking at checkpoint inhibitors in the neoadjuvant approach, and we have some pretty interesting and durable responses in a subset of patients that is really getting us excited that this may be this kind of approach to doing clinical trials in glioblastoma may be the right approach in terms of accelerating development. And the real reason is because when we do radiation, the tumor microenvironment changes. And so targeted therapy or even immunotherapy becomes very difficult to see an effect, or the complications of our treatments is very hard to manage because of edema in the brain after radiation and chemotherapy. So we've been really trying to figure out how to do things better, and we have a pretty unique design that we're trying to do for all of our clinical trials and with all the new drugs out there. But we do have to select patients at the same time. You can't just use the same combination of drugs on everyone. You have to actually select different combinations for different subsets of patients based on the markers.
And I think that's what people I think may not appreciate is that before and all the data you look at backwards, like, man, we really haven't gotten a hold on this cancer thing. We literally took the tissue and just looked at it and said, okay, it's squamous cell or it's small cell or adenocarcinoma, and really just tailored therapy to that and the tissue of origin. Now, of course, there's some other immunohistochemical stuff, IHC and
Yeah.
stuff, but it was like histopathology. And if you're listening to this and you're saying, whoa, you're telling me like it's way past that, and you actually sequence to see which of the tiny little switches and needles that go up, like when you're taking apart this crazy electronic device and you see all those things and you're just like really intimidated. That's what we're inside the tissue and we're looking at all these things. Was it something you were born with? Was it something that was in a lifetime? And you're asking yourself, how will we ever figure it out? My question would be, wouldn't it be faster if we all knew what was happening with like this series of like switches up and down this way, left, right, right, and then when drugs were given, right? That's what data, when people studying cancer want to know data, they don't want to know like your social security number. They want to know what are all the constituents about your tumor and about you yourself, and how do they play a role on what works and what doesn't work? And then we have AI technology. You can figure out, you can do the algorithms and say, hey, there's a really good trend to not respond to this drug if you have X7974, and then you go look into it. And then what if that becomes a great thing because now we're exploiting that? So that's the overall concept of data collection and moving that needle faster so that we can find these like what we understand to be very complicated mechanisms on a cellular level. So when you hear sequencing, did you get it sequenced? Did you have like genomics? Did you have comprehensive, molecular testing? All these things you hear that are kind of almost dizzying with a cancer diagnosis, I'm sure. That means, are we looking at all the kind of individual things that are being studied, and can we make cocktails and basically have an influence on not losing time by giving something that doesn't work, etc. The other point is when you talk about GBM, glioblastoma, and you say that it's, harder, it has so many like tools. Tell me if I'm wrong, but the way I think of it is you could go to, like a handyman school or a handy person school and have everything, right? Hammers, nails, and everything. But the more you go into your trade, you get kind of like better differentiated. So you have a couple of things to just do and perform what you need. And so that's what happens with colon cells and these driver mutations that you're talking about that we can target. It's like they respond, it seems like, to monotherapies or one single therapies to single targets better because they just kind of had more of a refined purpose. But the way I think of central nervous system cells, they're way up here. They're the entire toolbox. They're even in your garage. And so when something goes wrong there, you have such a bigger challenge because they still have all the sets of tools. They didn't, you talk to even doctors, they're like, I don't remember my internal medicine. I don't remember my intern year, of like whatever before I became a dermatologist. You get more refined. Does that make sense? Or is that accurate? Is that they just have a far greater and yet ability to use tools to be able to escape and be nasty? Or is it just that it's just hard to get there or even deliver
Yeah, I
therapies?
think I think there's three main reasons. One is the heterogeneity of GBM, the mutational load or complexity is above average compared to other tumor types. The blood-brain barrier is probably the biggest thing in terms of drugs getting across the blood-brain barrier and having activity in the brain. So many of the drugs that we use were not developed for glioblastoma. They're developed for breast, lung, colon, whatever cancer, and we're trying them in glioblastoma because that's all we have. The pharmaceutical industry just hasn't focused enough on developing new and specific agents looking at the biological underpinnings of glioblastoma specifically. Except, during my training at Dana-Farber and when I here in California, we did develop a drug that hits the Achilles heel, the cancer stem cells of glioblastoma. And excited to say, after nine
Whoa.
years of working on it, we just got our phase one IND approved. So I'm super excited that we'll be able to do clinical trials on it later this year. But that's like was designed specifically for glioblastoma based on an understanding of glioblastoma stem cell
High
biology.
five.
Yeah,
Yeah, that's
we're
huge.
super excited. It took 9 years, but we're getting there slowly. But we need to do more of that. There's actually other targets too. So we need, scientists, pharmaceutical industry, and obviously other people to help think about medulloblastoma, glioblastoma, meningioma, and looking at what the specific drivers are, and identifying targets and developing drugs for that particular disease, and drugs that get into the brain as well, because many of the like the BRAF MEK inhibitors, EGFR inhibitors, in the initial versions of all those, they would avoid the compounds that went into the brain because they didn't want to deal with brain toxicity, right? So now,
Right.
we
And
have
now,
all these new generation, yeah, of EGFR, ALK, ROS inhibitors that they purposely made them get into the brain, NTRK inhibitors, et cetera. They didn't exclude them. So they may have quite a bit of activity in brain tumors if they have that mutation. So, but so the blood-brain barrier is important. The other thing is when we do immunotherapy in the lung or on the skin, a little bit of inflammation, we can tolerate a little rash, little, shortness of, not shortness of breath, but a little cough. When it gets severe, you have to give steroids. In the brain, a little bit of inflammation still causes a lot of problems. That's a real
no
issue. So
space.
how do we manage the inflammation? You can't have it too much, and you don't want too little. So you want that perfect balance. And so we are trying to figure that out. What is the perfect balance of immune therapy, whether it's checkpoint inhibitors, personalized vaccines, or other drugs to have an effect and manage the toxicities optimally. Because a seizure or worsening neurological function, we end up giving steroids to control that. So the tolerance level in brain is much, I think, much less than most other organs, and that's why it's a little bit more complex and a little bit more thought has to be put into how to do immunotherapy in the brain to maximize the effect and reduce the toxicities.
And
But
I mean, in some way, it's the way that chemo was first designed, right? Cytotoxic chemo. It's like, how much is too poisonous for the human body and all the organs, but how much is enough to kill, like to kill the cancer cells that replicate the fastest? You're doing the same thing, but on a whole nother, way more like, specific and intimate level. And then the challenge is, like you said earlier, you and I are similar skin tone, but your perfect little teetering, perfect little balance may be different than mine. And then what about somebody on the other side of the planet? And then what about a female? And so then you need that's not you, that's your buddies. Then now that you have to work with to say, hey, this is what I found on this side of things. But then what are the things that play a part into really even when I give it, if it's too much or too little?
yeah, no, it's a very complex thing to think about on a per patient level. But this is where the pharmacogenomics and all the
Right.
testing that is becoming even, every baby that's born is getting their whole genome sequenced in the future. It's going to be part of your medical record. You're going to know your allergies before you even try something, right? You don't know you're allergic
Right.
to something until you try it.
With no exposure. Yeah.
The same thing with drugs. You don't know whether the cancer is going to respond or not, or whether you're going to have a severe side effect or not without looking at pharmacogenomics. And I think so. We're going to have a blueprint in the future for all kinds of things that we can use, but it is about big data at the individual level, but also big data at the population level. And this is why I love being part of my hospital health system, Providence St. Joe's Health, because I'm doing my trial at one hospital, but I'm expanding to multiple hospitals in Southern California to provide patients in community settings access to the best and greatest
That's awesome.
trials that any academic medical center would have. And then as part of our, 50 plus hospital system, if I can organize this network to provide high level, research level care at the community hospitals, we can accelerate drug development in a way that I could never have in the past. And that's really what's exciting. And the fact that the genomics is expanding, the fact that we're getting all this data from everyone, if the amount of data on an individual basis is so much, you need a large population of patients to be able to
Have to.
weed out, what the variables are that are significant for response or not, and side effects, et cetera. So it is a really exciting time for neuro-oncology, for all of cancer, and a lot of medicine, in terms of what we can understand from every patient and how we can learn, about the individual heterogeneity and variation, and really optimizing, the therapeutic benefit for each particular patient.
So to the effect of accelerating everything as fast as you can, all these complicated stuff that you talked about that you specifically are just moving mountains with, at least, or trying to get everyone on board to move the mountains with. Your pan director or chairman or something of everything out where you're at. But one of those things is translational medicine. And I've used this term before on previous podcasts. But can you tell us, in the it's not that simple. What is translation medicine? What do we mean when we say that's what we're looking into?
The network is important because brain tumors are now very common, and if I want to do a trial in a biomarker, 10% of patients have it, GBM, it'll take me 5 years to enroll all the patients at one site. But having a
Right.
network, you can enroll all the patients in 1 year and get your answer and keep moving on and asking multiple
Then move
questions,
on.
yeah, etc. So that's the power of a organized health system or network to do research, is really to accelerate research like never before, and that's what I'm super excited by. So translational medicine is really the intersection of medicine and science. So as we treat a patient in our clinic with any standard treatment or a clinical trial, we collect samples, whether it's the tumor tissue or the blood, and we kind of do various testing to figure out why that patient responded or did not responded, or
Mm.
how the cancer changed over time. So there's a hypothesis you can do in the lab. I can do tests in animals, etc., and then use that idea in the clinic. The other approach is I'm already treating my patients in clinic. Some patients are responding, some patients are not. I want to learn about it, whether it's sequencing the tumor or whatever other marker I think is important in the immune system. And then I'm going to go back and see why this person responded, this person didn't. And we actually did this in many times over the years and identified
Mm.
markers that helped us then, it's called reverse science, basically, from the bedside to the bench. We validated in the lab, and then we went back to the clinic and did a prospective trial of using that marker and designed a better trial to enrich for that marker and get a better response. So I think that interaction of the basic science and the lab science is translational science. And that's really something we need to spend more effort on, because especially in glioblastoma, where we're treating patients off label with combinations of drugs, we should really be understanding, whether they responded or not. And that's really, I think, what, again, a network of hospitals or a health system can do much better than an individual hospital. And I think that's where the power of numbers is important to really identify what's a good drug or not, and what the markers are.
If you're listening to this and you haven't experienced a personal one of a loved one or friend or whatever, and says like, they got the treatments, it was supposed to work, and they just like spiraled, or they just like everything, nothing responded, and they passed away quickly or was bad. If you're wondering that and you're frustrated, that is to your point, which is it's because we need to know and understand what are the extra additional variables on a much smaller level that account for that, so that the next loved person in that similar circumstance won't have that, the expectation of what usually happens and doesn't. And I don't mean by error or anything else, but just, so many other properties that we need to learn and understand. And that's what translation is. This is what we can, observe in a lab. Does it work? Oh, sure enough, it does. And vice versa also. This is what we understood, but this is not what's happening, evidence based. Let's go back to the books and figure out, is there anything else we're missing? Dr.
Absolutely.
Kasari, has been an absolute pleasure. I'm just, you always, hearing you speak, I've listened to you previously. It always just inspires me to I just feel like I'm not doing enough. I just like get up and I lose sleep, and now I'm going to go back to the sleep because you just told me that that's actually very healthy for that, that kind of that clearance of my toxins. So that's a big take home piece. I hope everyone took that away. Is that you're truly, the evidence has shown recently, you're truly hurting like a bunch of stuff and possible depression and muscle pains and all this kind of stuff with poor sleep. But that was just one of many, many points. And is there some message that you would like to leave with because I'm just going to be bugging you in the future because I just think,
Yeah.
I mean, you're, yeah,
Well, I think
inspirational.
even though I've been doing this 20 plus years trying to cure brain tumors, I am actually even more excited and hopeful in the last few years than I've ever been by the innovative. I think we need to design clinical trials differently, but the awesome thing is there are so many drugs out there now approved for other cancers and drugs in development. So we just need to get our act together in terms of, again, sequencing. Well, what is the makeup of the tumor? What makes the tumor tick? What drug or combination of drugs could help a particular patient? And then design a focused study. Because if you find that perfect combination, you don't need to do a 100-patient study. You may get an answer in 10 patients. And so I think the more understanding of the science, the drivers of glioblastoma, the better drugs that we make, the more opportunities to accelerate cures for this disease. And I am really excited, I think, for the next 5 years or so, that I think we're going to see a lot more progress happen faster than ever before because of the
And
genomic advances and drug advances, and immunotherapy is huge. And I think it's going to have a role as well.
and also because of you and everything you've done in your career thus far and is still ahead of you. Thank you so much. Seriously, it's an absolute honor. I hope other people are as inspired as I am, but also kind of have this, again, this humility of us as, with our mortality and the complicated nature, no pun intended, of science and everything, and what people are really doing and working hard to try to combat is really the biggest challenge of humankind as a whole when it relates to cancer. So, thank you so much.
Absolutely. Happy to have this conversation with you and look forward to more, Sanjay.